Good night, everybody. Can you watch my screen? Can you hear me clearly?
Yes.
Okay, perfect. 8 and 9 is your decision if you want to start or you prefer to wait a little bit. At this point, we are 8 people just. It's your choice. Do you want to start now or maybe wait 2 minutes more?
Personal opinion, we can start, so we finish early.
Okay, let's go ahead. I think it's enough time to expect. We are here. But please let me know if there is any trouble with the audio, okay, for changing device if it's necessary. Today, we are going to talk screening and immunization. Of course, as always, a general view of them. But we have to be clear on this. If we make comparisons between health programs or vaccines programs around countries, we can notice that they are very similar. That's why we are not emphasizing on that. We are checking general lines, some expressions, some ways to talk about them, and details about worldwide vaccines, considering travelers, okay? That's why this point has to be so clear. Talking about epidemiology, I mean general concepts, general ideas about all of this medical branch, that is common for almost all healthcare providers. So it's important to consider this as concepts that we all know get in mind during the career. And also medical ethics. Medical ethics as general, of course, we all know the 4 pillars about medical ethics, but according to your own career, could be different. So I think the difference is not so big, not so huge, but we have to take it in count, okay? Let's start with the screening and immunization, okay? When we talk about the screening, we have to be clear on these concepts, on these ideas that are in the paragraph. And all of these situations are going to show us the way we should understand how screening could be done and how it's developed and how it should be understood. That's why screening as a word is a way of identifying people at increased or greater risk for a condition, although they don't yet have any signs or symptoms. In some cases, the mass screening in large numbers of people is appropriate. I mean, in a population, right? For example, in the past for tuberculosis, we know tuberculosis is a very common disease at this point. So the screening, talking about it, is very interesting because it's not just for a group, it's in the complete population. We all are in risk at this point, okay? In other cases, only those with high risk factors, like family history of conditions such as cancer and diabetes, are screened. We have to consider this. High risk factors, we all know about the meaning of this expression. When we have relatives in the first line, I mean parents or siblings with these situations, we must consider as a high risk factor, right? So, on the other hand, there are a number of problems with the screening, of course, and we always have to consider the false negatives and, well, that cases where a patient has a disease, but the screening doesn't identify it. It's a false result. We all know it happens when it's done in a large number. And false positives, of course. Someone is told they have a disease when in fact they don't. It happens. That's the risk we get when we make a screening in a big mass. Furthermore, with some diseases, early identification is no benefit to the patient as there is no treatment available. We all know at this point we still have some diseases that are without treatment. So we have to be clear on this. We have to be serious and consider that during the screening we can find these situations. Generally, they are genetic situations without treatment, without the, well, we cannot imagine to live with a situation that has no treatment and no cure, of course, no way to control it. Just wait, expect, and get the bunny of scientifics in order to understand and learn how to develop with this. In this chart, we are checking common screening tests, the common ones that during this program we are checking. So, taking into account, we might consider that all of these conditions are situations that we can diagnose in the primary level. I mean, we have tests for developing. According to this, we have the diagnosis, and following the diagnosis, we can continue ahead. The subjects, the population that needs the screening done, are in this column, and the frequency, how and in which period of time it's better to do this. For example, the neural tube defects and Down syndrome risk, we develop the AFP, the alpha-fetoprotein. Subjects, of course, pregnant women, in which period of time? Between 16 and 17 weeks. Following this, we can complete this screen, and we can give parents the possibility to decide if they want to continue or not with the pregnancy. In many countries, it's loyal to do that. In our country, in Bolivia, of course, we don't have the chance to make an abortion like that. Maybe in a very, very specific situation that is under the laws, but it's not very common to check this. At least the woman, the pregnant woman, is a teenager or a kid, right? On the other hand, we have breast cancer. One of the common tests that is developed for this is the mammography. It's developed in women between 50 and 70 years old. And it says every 3 years. Every 2 years if you don't have any risk of this condition, of this disease. But if there is something that could give possibility to get breast cancer about family history, no matter which one, or you have a relative or a sibling with that, it has to be every year. That's the difference. The same with the cervical cancer. In our country, well, in Latin America in general, we have to develop this test, the smear test, in women between 20 to 60 years old every year, not every 3 years. We open the possibility to make every 3 years or even though every 5 years, if there is a woman older than 60 with at least 3 smear tests negative. According to that, it's possible to give it an extra space. About cardiovascular disease in general, we consider the blood cholesterol. It's developed in patients that are 40 years old and ahead with high risk factors, not for everybody. High risk factors, I mean obesity or hypercholesterolemia, cholesterolemia. And well, it has to be developed every year. If one of these situations gets positive, you go to the secondary prevention. I mean, just as an example, there are these 4 conditions. In the secondary prevention is when you get the diagnosis, for example, of diabetes, you are a patient with diabetes. The secondary prevention is looking for complications of diabetes. In this case, talking about diabetic retinopathy, we must develop the ophthalmoscopy by the ophthalmologist every year. Or if there are complications when your sight is in trouble, it has to be every 6 months. It's according to the situation. Or if you make the blood cholesterol and then found that your cholesterol is higher than 4, you have to continue in control with the same blood cholesterol in patients with a heart disease previously diagnosticated every 6 months. According to that, you have to choose which one is for primary prevention or secondary prevention, okay? Just as an example, of course, there are so many situations to consider in this common screen tests, but for catching the idea, this is an important chart. Some common screening tests are in this list. Take it in account. We have the Papa-Nicolau smear for cervical dysplasia or cervical cancer. The fasting blood cholesterol for heart disease. Okay, the fasting blood sugar for diabetes. That's the first step, you know about it. Then we have 3 tests more. The blood pressure for hypertension, considering the correct technique and schedule to do this. The mammography for breast cancer. The PSA test, the prostate-specific antigen for prostate cancer. We know about it. Fecal occult blood for colon cancer. The ocular pressure for glaucoma. The PKU test for phenylketonuria in newborns. We know that it has to be developed in the first month of life. It's better if it's done in the first 5 days of born of the life. And the TSH for hypo or hyperthyroidism. These 2 last ones, the PKU and TSH, are done in the first 5 days or even in a week. It's according to the place. I was forgetting this. These 2 ones are the heel screening test. Okay, la prueba del talón. So don't forget it. Talking about immunization for travelers. Well, it's very important to take in account this part, because we always have the chance to work with someone that is coming from another country, another place, no matter if it's another place into our country or, I don't know, maybe coming from Santa Cruz, for example. Or we have the chance to become a traveler. We have to consider that when we become a traveler, we have a specific microbiota in our body, and it could change. And well, we have to be prepared. At this point, travel vaccines are specific immunizations that give the travelers prior to going to certain areas to protect them from occurring serious or life-threatening diseases. I mean, if you want to go to some other countries, you have this slide when, according to the place, to the continent or the area, you have the list of vaccines you should have. If you want to go to the Central and South America, you need the anti-influenza virus vaccine, anti-yellow fever vaccine, malaria vaccine, rabies vaccine, typhoid vaccine, hepatitis A and hepatitis V vaccine. So with all of them, you can get into the countries that are in this area. When you go to North America, when this chart was done, it was just anti-influenza virus vaccine, the most important, known for everywhere. The anti-COVID-19 vaccine is required. According to the place, you know, the lab that is developed. But getting back. When we say fully vaccine traveler, we mean that if you as a traveler have received both doses of an accepted 2 vaccine series, regardless of how long it has been between doses, you are considered fully vaccine. I mean, almost all the vaccines require the first vaccine at the moment of receiving the immunization, and requires a second doses that could be applied 10 years later. For example, with the anti-yellow fever vaccine. When I got my scholarship and went to Cuba to study, to take the career, I had to get the anti-yellow fever vaccine in the previous 6 months of going to Cuba. But if I want to go back, I have to show my first carnet, my first ID showing that I received the first vaccine, and then a new one supporting that I completed the second doses into the 10 years that are supposed to be. If I get the necessity to go there and I have both doses, of course, I'm fully vaccinated to anti-yellow fever. Okay, I have this chance. If you want to go, for example, to Asia, the anti-influenza virus vaccine has to be the vaccine of the year. It's not viable, it's not correct to go with the previous one, because we know that every year virus changes and the situation is different. For example, hepatitis A and B only have 1 doses, but you have to support, well, not 1 doses, have a series of doses between months until 5 for hepatitis B. So you have to support that you received all of them for getting admitted into this area in Asia in general. Okay, so fully vaccine means to receive the first vaccine and then the support, the second doses, okay? This chart is just showing us vocabulary. Don't worry about it. The explanation is so easy, I think. But it's showing us some vocabulary that we must consider and practice in order to be ready what we are talking about. For example, hepatitis or immune globulin G, IG. Transmission of hepatitis A virus can occur through direct person-to-person contact. You know, black words, vocabulary, okay? Through exposure to contaminated water, ice, or shellfish. Harvest in contaminated water, or from uncooked fruits, veggies, or other foods. So taking this into account, this small paragraph with information, we got the vocabulary. For example, malaria. Your risk of malaria may be high in these countries, including cities. Travelers should take an effective anti-malarial drug. The anti-malarial drug is awful. It's worst to take the preventive treatment than get with the disease. Of course, it's for 2 weeks, the preventive treatment, but you get destroyed. It's not... It's better to get vaccinated than taking that medication for prevention. For example, the rabies. If you might have extensive unprotected outdoor exposure in rural areas, you must get this vaccine about rabies. Just for consideration, please read this, catch the vocabulary, and according to that, we can talk tomorrow, considering the new vocabulary and expressions that are here. Practice, please read on this. Okay, let's go to epidemiology. We know that epidemiology is a huge, very big branch in medicine, of course, and in healthcare providers, of course, and in general words. At the university, we have a career that is about epidemiology. So when we talk about this specific branch, we must consider that numbers are the ones that are talking here. We look for objective data, objective information, no ideas, no conclusions without a basis. So in order to support that results, we must be clear that we have to work with formulas, with mathematics. Lots of us hate that. It's not for us to work with numbers, but it's the requirement for doing it properly. Epidemiology in general words is the study of the distribution and determinants of health-related states or events in specified populations and the application of this study to the control of health problems, talking about health branches just. When we take the infection control, it's a very huge study, as you can see in the picture, because you have lots of activities to develop, lots of ways to start working, lots of material you really need in order to make it great. Sometimes it's not possible, but it starts from us to make our best effort. When we consider the epidemiological department, epidemiologist has to get information, and the information comes from public and healthcare providers. I mean, clinicians, laboratories, and hospitals. Every place when a patient receives a treatment and has a medical report, has a file when you can show the information, when you can support the information of the patient, explaining what is going on, and we can convert that information into numbers. That's why epidemiologists take this information, prepares a report, and this report goes to the health department of the place. In our case, goes to the CDS and the Ministry of Health, and they make the feedback. They prepare all the information, prepare all the incidence prevalence of many situations, and this feedback goes again to the public healthcare providers in order to improve the attendance, to improve their job. That's why it's important to consider this cycle. It never ends. We all, the ones who had the chance to work with a clinical report, clinical history, have the chance to be a small piece of this branch. And we have the chance to give this information. It's the same everywhere in the world, how it works. We receive information, we report it to our superior, the superior prepares the feedback, and then we know which, we can say which mistakes we have to solve in order to improve our job. Let's talk about some concepts, general ideas that are necessary to take in account. First of all, we have the rates. And well, rates are the speed or frequency with which an event or circumstance occurs per unit of time, population, or other standard comparison. Rates are just comparisons, okay? According how they work, you can see. When we talk about rates, about frequency, we use this, for example, birth rate. And we know that is the number of births in a population. Death or mortality rate, the number of deaths in a population. Case fatality rate, the number of deaths from a particular disease. And survival rate, the number of patients still alive after treatment of a particular disease. I mean, all of them are the object of the study, but when we say rate, we must understand that we have to check the number of this situation. Well, we have two examples that, well, I think that Chamboneros were. Two examples in the book. The birth rate in Singapore is 10.22 per 1,000 population, okay? And the infant mortality rate in Singapore is 3 per 1,000 live births. Okay. Synonyms or other words used to talk about frequency, we can say when we don't use the expression rate, we can say malaria is common in many developing countries, or malaria is uncommon, or malaria is rare in developed countries. According to the numbers, to the results of the rate, we have to decide if it's common, uncommon, or rare. Uncommon or rare, consider both of them as synonyms. So it's your choice which one to use. By personal, I prefer to say common and rare for not mixing ideas. But it's your choice, as I was telling you. Here you have some charts, the pie chart and the line chart, showing you the rate and showing you the year, the period of time, and how it increases. In the pie chart, you can see by percentage and colors and make the comparisons about the situation that it's in a study. It's just an example for showing you how it's done. Okay, let's talk about incidence and prevalence. As idea, as a general concept. When we get prevalence, the number of people in a population who have the disease at a particular time. We have the formula prevalence, all cases over population in risk. And incidence, the number of new cases in the disease during a particular time. I mean, incidence, the new one, new cases over population in risk. Incidence, new one, prevalence, the people that is at the moment with the disease or with the situation. While talking of this, about incidence, you have the chance to do it by this way. The incidence of malaria is high in many developing countries. So you don't have to give me the number, just telling me that it's high. I can notice that the quantity is elevated, or the incidence of malaria is low in developed countries. So when you tell me low, I can infer that the number of cases could be unremarkable, even though could be not so common to see, I mean. So take these expressions in count, because that's the way that we can get in contact. For example, the incidence of HIV infection is highest in sub-Saharan Africa, and that's true. Or we can say the incidence of HIV infection is lowest in the Caribbean. It's not true. Okay, when you say incidence, you cannot say common. Of course not. You cannot say that the incidence is common. No. It's or high or low, but not common. You can use common when you make a comparison between two groups in a study according to a specific situation. Okay. For example, when you want to use common, as the line says, the incidences of a disease in different groups are often compared. When you compare, you can use common, less common, more common, or equally affected. Take this in count. For example, rheumatoid arthritis is more common in females than in males. Well, we know that's just the comparison. The common one we use in social English is the same, but we don't have to mix the idea. Again, when we want to emphasize the number without telling the value, without telling the number, we can use high or low. When we want to make the comparison between two groups in a study, we can use common. More common, less common, or equally affected, okay? Rheumatoid arthritis is less common in males than in females, okay? And the last one, men and women are equally affected by restless leg syndrome. So you can see how the comparison is done with the common word, with this expression, and how to use high and low for not showing the number, just giving an idea how the situation is going on. Talking about association and causation, we have to take in account that these ideas, these concepts, are clear enough in order to understand that the studying of the incidence of disease in a particular groups of people can lead to the discovery of causation. What makes it occur? I mean, what's the cause of a situation? We don't have to give just the first answer we have. We have to study why the situation is coming from, where it starts, how it develops. And that's the causation. What makes it occur? Why it happens to this group of people specifically. For example, the high incidence of lung cancer among cigarette smokers suggests that smoking is a causative factor in the development of lung cancer. We all know about it. And it has proof, it has science that is supporting that lung cancer, one of the causes is smoking. It's one causative factor. We all know about it. But of course, there are more situations that can give us the answer about lung cancer. Not all smokers are going to become with lung cancer, and not all non-smokers with lung cancer are smokers. Well, we know, you know, that you catch the idea. The causative factor has to be studied. However, care must be taken not assume every association between a disease and a measured variable is causative. I mean, these associations are the ones that has to be studied. These associations, these details has to be so clear, and we have to identify the causative factor for every patient. To say there is an association between two things simply means that they occur together in a certain situation, in a very specific situation. For example, several studies have indicated high rates of lung cancer in cooks, right? But it doesn't mean that cookers are smokers, although this could be a consequence of their work, right? Perhaps caused by carcinogens in fumes from frying, for example. It may be simple because professional cooks smoke more than average. Because of their job, they have a causative factor. You can see the causation is not smoking. It's because of their job, they smoke that gases all the time, and that's the causative factor of them for catching lung cancer. In other words, smoking might confound the association with cooking. That's the point, to divide the idea. That's the point, to identify properly. That's why we are talking about causation, causative factors. In this chart, we can say risk factor, component causes, biological effect, and health outcome. The risk factor, losses, and social determinant. Losses are people without all the social resources, all the resources for becoming in a good way of life. It's like to say, the third world, the poor ones, the poorest ones, right? The component causes, tobacco, smoke, pollution, of course, and biological effect. The result of this association between risk factor and component causes is the biological effect that shows mutations in respiratory cells, and the health outcome, of course, lung cancer. Very easy to check this chart. To understand, it's clear to catch the idea about the causative factor. Well, medical ethics, I think we all have the chance to consider these situations, because it's not easy to get in an ethical situation, I mean. Medical ethics is concerned with the obligations of the doctors and the hospital to the patient, along with other health professionals and society. The health professions has a set of ethics applicable to different groups of health professionals and healthcare institutions. I mean, we all have the chance to practice on this. We know about it since we started the career, but through the time we realize the responsibility we are catching, we decide to take. Okay. And of course, we have our 4 pillars of medical ethics. According to these 4 pillars, we have the chance to work properly, to work nicely. We got the pillar of beneficence, the pillar of non-maleficence, the pillar of autonomy, and the pillar of justice. The pillar of beneficence, well, let's read this. It's about promoting the good of others. In medicine, in healthcare careers, I mean, it means acting in a way that helps your patients. The most obvious example of this, providing up-to-date, evidence-based treatment for your patients with the aim of reducing their symptoms or treating their illness. So there is no way to say that we are not in this branch. We don't know what we are talking about. We know that the pillar of beneficence is supporting our job, because we all know, well, we look for this. In this blue chart, I'm showing you some examples how the pillar of beneficence is broken. The Tuskegee syphilis trial is a very important trial developed in USA, when the public health service decided to study how syphilis was developed, was affecting the body. But in a population of low CES, in a low CES population, yeah. Well, poor people without knowledge, without the studies, people that didn't have the capability or didn't have the studies for understanding what was going on. So they become the bunnies. They divided the community into groups. The first group was receiving the correct treatment with penicillin, and the second one was without medication, was with a placebo. And they could compare how penicillin was going on, how recovered patients were acting, and how everything was changing from syphilis. And in the second group, they decided to study how the phases of syphilis until neurosyphilis and of course the death. This is a very controversial trial because that was the point where the treatment was developed, and well, we know that was effective, but we decided to do it by free. Lots of people dead, of course, in a non-common way. It's so sad when you find it. There's a movie actually that if you could watch it, it's amazing how people from into the community didn't know about it, but when they realized that they were the bunnies of this trial, of these tests, they tried to kill doctors, of course, because they were having fun with their lives. So the pillar of beneficence was broken. And just as an example, we have lots of examples about it. About the pillar of non-maleficence. Well, non-maleficence refers to not causing harm to your patient, not acting like with intention. This principle spans a range of applications such as doctor maintaining medical competence and not giving patients treatments where the risk is outweighed the benefits. We all know we have to make the comparison about benefits and risks, and then we decide which one is the best. It seems obvious that doctors would not want to harm their patients, yet there are countless examples when this principle has been disregarded. If you don't have the experience, don't do that. If you don't have the practice, don't have the competence, don't do that. It means non-maleficence. If you don't have the studies, don't get into the case. You can learn, but you cannot go and try to identify or to learn while the process. That's not the idea. Stay up to date, keep on reading, keep on practicing for not getting into or not breaking the pillar of non-maleficence. This is an example again, because Harold Shipman was a general practitioner in England, a GP, who decided to kill patients, elderly patients, providing and testing high doses of opioids in order to finish life. I mean, applying something like euthanasia without permission, okay? Without the knowledge of the family or the patient about the process. Read this chart, this box. It's very interesting, and there is a lot of information about it. It was very controversial. At this point, there are many serial killers that are found in healthcare systems that act in a similar way, just applying medication in very high doses or avoiding medication for causing harm. They are breaking the non-maleficence pillar. That's a very interesting way to understand this. Then we got the pillar of justice. The principle of justice refers to fairness within medicine and equal distribution of resources. It can be considered in terms of equality of healthcare across patients. I mean, when we have equality, we have all resources for everybody. All the benefits are the same, no matter the situation. But as you can see in the picture, it's not correct because he has a benefit, but he is without the benefit. When we talk about equity, we can say that everyone gets the supports they need. He is without the support, he has a little bit, but he has too much. So it's not possible to make it. Because we cannot live a population, we cannot live a patient without a support. When we decide to talk about justice, I mean, we have to look for the way to set equality and equity in the same proportion to everybody, to everyone. That's why we look for the way to do it. That's the idea of working in public healthcare systems, but we know that it's not possible to make it, okay? Equality, equity, and justice, just for catching the meaning of this. And the pillar of autonomy, self-determination. By personal, I hate this pillar because it refers to a patient's right to make their own healthcare decisions. This is also known as self-determination. They can decide if they want to receive treatment, want to receive a procedure, or want to be a part of something extra. Okay, patients can decide their own healthcare priorities, and it includes their right to refuse treatment. I hate when people refuse treatment because sometimes because of fear they do that. But it's their choice. We only give suggestions, we give ideas, we show the best way to do something. But if the patient says no, there's nothing to do. We cannot oblige, we cannot force a patient to take a decision and go ahead. We have to respect, we have to be serious on this and say, okay, even though if we know that the treatment would save a life, we have to wait. We have to, well, we have to take in count, to take a deep breath and continue, okay? We as doctors, as healthcare providers, we give the complete information, we advise, okay? We use medical evidence to support these decisions, but the patient has the right to say no, to say yes, to think about it. So anyway, no way to do it. Sometimes at the beginning, patients can deny a treatment, can say that they don't want to do the procedure we are explaining. But while checking that the health situation is going worse, they change their mind and they look for another opinion, and they later tell you, okay, I want you to make the things you were telling me, exactly that expressions. Do your job. You reevaluate the situation and you have to start again from zero and explain the new, how the complications are going wrong. And that's the way when ideas can get worse with the patient. And they say, no, but you told me at the beginning that developing treatment was the best. Now you don't want to do it. That's complicated. That's why everything you inform, everything you say, and patient is denying, you have to write down, make them to signature the file, and maybe using the thumbprint, or not avoiding that responsibility in the change of the situation. The pillar of autonomy is very easy to break because, we cannot decide. Specific situations when we can decide is when life is in a real risk and there is nobody who can deny for the patient. For example, a very common situation. A Jehovah's Witness who may refuse a blood transfusion on religious grounds, okay? If they say no, for example, it's a kid who really needs this blood transfusion and parents say no, there is no way to do it. No way, because they are the loyal responsibles. They have they have their reasons. We must understand that there is no way to do it. This may seem medically unwise, but the patient has the right to refuse this treatment. Okay, the autonomy brings together medical ethical challenges, including the areas to consent and capacity. But what happens if the patient is alone? I didn't know that was a Jehovah's Witness. And, who has the chance to decide? instead of the patient, me as a doctor. That's why it's possible to break it. Okay, so it's controversial to talk about it. You don't have to specifically, if life is in risk, I tell you by experience, is in a real emergency, you don't have to wait for a relative or someone to tell you, yes, go ahead. You have to take a decision and go ahead and try to save that life. All the consequences are coming later, but it's better to deal with the consequences than with the guilty of doing nothing, right? The General Medical Council guidelines, it's a paper, it's a guideline that is useful in UK. When you have lots of steps showing you that how to work, we can say, how to understand the responsibility to become a doctor, to become a general practitioner. And all the doctors that have a register that are working, have to learn it at least once to understand it. They are around 14 points, but the first 9 ones are the most important ones, in my personal opinion. You have Latin words for vocabulary, so practice them, memorize the expressions, okay? For example, make the care of your patient your first concern. Okay, treat every patient politely and considerately. Give patients information in a way they can understand. It's not the same to talk with a lawyer than talk with a farmer. We all know about it, no matter the situation. Try to be on the shoes of the patient, and it's going to be easier to get in contact and get the best answer. Okay? Keep your professional knowledge and skills up to date. So important. Keeping up to date, it's possible to make it. Recognize the limits of your professional competence. Recognizing your own professional competence, it's the best way to avoid loyal troubles. If you don't have the qualifying, if you don't have the competences done, or the courses or the resources done, don't do that. Don't become don't break the pillar of non-maleficence, okay? Be honest and trustworthy. Respect and protect confidential information. I mean, all the contact with your patient is confidential information. You don't have the right to go and spread, right? Make sure that your personal beliefs don't prejudice your patient's care. You have to be so clear on this, and it's not easy. Well, again, when I was at the university in the last year, I had the chance to be as a general practitioner because that's the way of studying and living there. When you become in the internship, you have the chance to start developing your medical thoughts, your medical ideas, your medical plans. But the fact of being Bolivian was a prejudice with the patients for many political situations. No other thing. Yeah, the fact of being Bolivian was so hard to treat sometimes with other colleagues, with other students, but it doesn't have to be a big trouble if you work properly. Okay. Act quickly to protect patients from risk if you have good reason to believe that you or your colleague may not be fit to practice. I mean, if you see or if someone asks for help, go and help. That's the best part. And if you consider that a colleague could be or could make a mistake with a technique, a maneuver or something like that, or you see that it's possible to go and help instead somebody's not asking for help, there are many ways to arrive the situation, to correct it, and to protect patients from medical complications, we can say, right? Well, bioethical issues always are a trouble, always get us in many situations. For example, the euthanasia. Well, is that correct for us to decide when life has to end? Is that correct to let people decide when they want to die? Or we should expect until God or that superior energy decides to take it away? It's very, very complicated because, for example, in our country, it's not possible to make it. It's not possible to develop euthanasia as a fact, as a law. Even though if they are terminally ill patients, we don't have the chance to do it. Patients has to suffer, has to die, in my personal opinion, according to the situation. Sometimes could be necessary to consider euthanasia for avoiding pain. There is a point, there's a limit when medication acts. If you break out all the limits, it's not possible to do anything. Well, consider this. But it's my personal opinion. So cruel, I know. About human fertility, of course, there's a huge trouble at this point. Everywhere, every place has its own rights, its own way to do it. About embryos can be frozen or not, or if that's correct to use a womb from another woman to develop the pregnancy because the patient has not the chance, or the in vitro fertilization has to be the way to get pregnant. There is a reason why by nature it's not possible, but we are breaking the rules. While thinking on this, it's that okay? It's that possible to make it? Or what about transplant surgery? Who should give the consent for the removal of body parts? The patient or the relatives? Or it's better, in many countries, I mean, Europe especially, and USA, you have the chance to tattoo on your skin that you are organ donor, for example. Is that possible to make it? Is that correct to make it? Who knows, right? And even though if I have all the documentation done, but my parents decide not to give that permission, doctors could continue or not, right? It's complicated. So it's controversial. Let's try on this. Or about the genetic engineering. Is that okay to prepare clones for everything? For people, specifically from animals, in order to produce children? So are we going to design babies? What's going on? Is that's correct? I mean, medical issues that, well, ethics that is not possible to define. It's a very personal position, okay? About assisted dying, well, we have this paragraph showing us that it's possible to decide it according to the situation. But it's for USA, this paragraph, okay? So read this, practice on this, and catch the vocabulary. The Black words are developed in the second box. So read this, and any question, tomorrow we can talk about it. But read, it's like an extra job for working tomorrow, okay? And keep educating yourself. I know there is a lot of information again, lots of new words and expressions to consider, to take in account. So let's work on this. Let me send you the pool to take attendance, and according to that, I'm gonna upload the presentation. I hope it works tonight. Okay, can you watch the pool?
Yes.
Perfect. Okay. Okay, please. I'm uploading the presentation. Please give me a minute. It's not so fast. If it doesn't work, I'm gonna send to your WhatsApp, okay? Give me a minute. Don't leave yet, please. I need, well, can you all watch the pool, or is there someone who cannot? I need one more, yeah. Okay, I'm gonna send it again, Carla, and then you can feel it. Give me a minute. Okay, can you watch it now, Carla? Okay, perfect. Okay, I uploaded to the Zoom chat the PDF file with the presentation. Please try to download it. Is that possible to make it? Tell me, get it done, something like that, to realize that you get it, the presentation. And in order you download it, you can go for studying, and tomorrow we have the chance to talk about it. Thanks to you, Maria. Thank you for your attendance. Thanks everybody for your attendance. I really appreciate that. Thanks for being on time. Perfect. Tomorrow during the workshop, we are going to talk about the physical exam. It's so easy to make, so don't worry about it. Try to be on time, please, because it's 15 minutes is exactly the time we need to check this information and check the slides if it's necessary, okay? Okay, thank you. Thanks to you. Okay, have a great night, people. It's nice to get in class, to get in touch with you. Okay. Well, let's finish this. Yeah. Let's close the YouTube. Okay, Dalila, I'm gonna close this. And see you tomorrow in the workshop, okay? Try to get on time. Please send me a message if you are still on your course in Europe in order to take it in count. Okay, Dalila, so